I welcome you all. New concepts of visual hepatobiliary clinics from Institute of Gastroenterology, Liver and Pancreatobiliary Sciences at Sir Gangaram Hospital. With cooped up economy, with sinking economy and rising cases of COVID, our country, especially with poor health infrastructure, has really gone very down. To come out of these shambles and the crumblings, I think the best way is to come out with the academic feast, which will really have a positive thought process. With that in mind, we thought we will have a new concepts of avoiding the distance and joining each other by the e-conference, which we are holding for the first time in our new venture. And this is the usual time of the week when we tend to have our meeting. Continuing in that vein, today we have the 4th day of our visual hepatobiliary for our department. And what better way than to start with the inventor of the image-enhanced endoscopy. To talk on that, we have the celebrated professor of gastroenterology from Japan, Dr. Noriya, and I'll hand over the proceedings to Dr. Naresh Bhatt to carry it forward. Dr. Naresh Bhatt, please.
Yeah. Good evening. Thanks, Anil, for that introduction. We have Professor Uedo here with us this evening. And not only is Professor Uedo a pioneer and a leader in advanced imaging, but he has contributed immensely to the understanding of NBI with which he works. And he's a very dedicated teacher and a phenomenally committed endoscopist and an international expert in ESD and EMR. Professor Uedo, please.
Dr. Naresh, may I request to please keep up to the time. So today we have 7 sessions and let's hope we do not exceed the time. That is just a humble request.
Okay.
The format is that Dr. Uedo will be presenting it for 20 minutes and then Dr. Naresh Bhatt will carry forward the discussion for a total duration of 15 minutes. So the whole session is around 35 minutes. May I request everybody to please stick to the time.
Okay. Okay, anyway, thank you very much for invitation this time. So I'm very happy to share my experience, knowledge with this kind of very difficult situation with all of you. So my topic is image-enhanced upper GI endoscopy. So what is image-enhanced endoscopy? This is first described in a gastroenterology paper in 2008. The term image-enhanced endoscopy include various means of enhancing contrast during endoscopy. In the past, we used dye to enhance morphology. This is called colmoendoscopy. And recently, we use equipment-based IEE, optical technology, such as NBI or BLI or iScan. Okay, so why image-enhanced endoscopy is necessary? Because such kind of advanced lesion, maybe image-enhanced endoscopy is not necessary. However, for such kind of early stage cancer or even pre-cancerous condition, it is very difficult to identify and characterize with white light image alone. So in such case, what we have done so far, we take biopsy and analyze histology. However, if we use image-enhanced endoscopy, it improves identification of the abnormal finding of mucosa. And also, if we combine image-enhanced endoscopy with magnifying endoscopy, we can improve characterization. And then we can make diagnosis and make immediate decision making without biopsy. So recently, I have involved in a committee member of 3 guidelines. So actually, I review many papers. So this time I accumulated several papers related to image-enhanced endoscopy, recent papers about image-enhanced endoscopy. One of the guidelines which I was involved was a guideline for endoscopic diagnosis of early gastric cancer. In this guideline, we made one algorithm according to clinical practice. So usually we stratify or assess the risk of the patients and then try to detect some abnormal finding. And then for abnormal finding, we differentiated whether it is cancer or non-cancer. And then if we make diagnosis as a cancer, we make staging and then decide treatment method. So I would like to introduce some related evidence according to these kind of steps. So risk stratification. As you know, why risk stratification or risk assessment is important? Because if we can identify or if we can find risk factor for the patients, we can change the practice. So if the patient has a high risk endoscopy finding, we spend more time and then perform careful observation to detect a suspicious lesion. And also, if we find some abnormal mucosal changes or subtle mucosal changes, we can raise index of suspicion for the high-risk patients. And then after the examination, we recommend the surveillance endoscopy for the high-risk patients. So some endoscopy finding associated with the risk of development of superficial upper GI cancer is reported, such as melanosis in oral mucosa, or multiple rugose voiding area, or endoscopic mucosal atrophy, or endoscopic finding of intestinal metaplasia. So if we can identify such kind of risk finding, we can perform or change the practice like this. So one recent paper from Europe show that the NBI can detect intestinal metaplasia according to regular rich tuberous mucosal structure with regular vessels. So according to NBI finding, they show that they can make diagnosis of high-risk patients for developing gastric cancer like this with about 90% of sensitivity of specificity. Another, this is not the equipment-based IEE, but the chromoendoscopy. Chromoendoscopy also identify high-risk finding of development of squamous cell carcinoma. If we apply iodine to the esophageal mucosa, if we find such kind of multiple rugose voiding lesion, more than 10 in a one endoscopic image, he or she is a high risk for development squamous cell carcinoma. They show, Dr. Katada show that if patient has such kind of finding, within 5 years, almost half of the patient developed squamous cell carcinoma. And also they show that if they recommend alcohol stopping, stop drinking alcohol, risk of development squamous cell carcinoma become almost 1/3 of the continuous drinking patients. But smoking cessation does not decrease the incidence of squamous cell carcinoma, because most of the squamous cell carcinoma in such kind of patient is associated with alcohol drinking. So this is really identified high-risk patients and motivate the patient to reduce the risk factor for development of squamous cell carcinoma. So to identify such kind of multiple Lugol voiding lesion, high risk lesion, we have to apply Lugol iodine. However, recently my colleague, Dr. Ryu Ishihara and our young doctor found that NBI, if we find some multiple foci of dilated brownish vessel, it is closely associated with this multiple Lugol voiding lesion. So without spraying iodine endoscopy, we can recognize the patient risk for development squamous cell carcinoma. Next, I want to explain about the articles related to detection. This is a bit old paper, but published in 2010. But NBI represent superficial squamous carcinoma as well-demarcated brownish area with irregular microvessel pattern. So this is a result of multi-center randomized control trial. It showed that the NBI detect significantly more squamous cell, superficial squamous cell carcinoma compared to white light image. This is a more recent paper. This is not the prospective randomized control trial, just a prospective cohort study, but using propensity score matching, they found that this is comparison between NBI and iodine chromoendoscopy. So NBI showed almost the same sensitivity compared to chromoendoscopy. However, specificity and the overall accuracy was better than chromoendoscopy. So NBI can provide, is very useful for detection of squamous cell carcinoma. And how about gastric cancer? Recently, three multi-center randomized control trial, including our study, was published. So our study unfortunately failed to detect usefulness, superiority of NBI compared to white light for detection of early gastric cancer. But the other two prospective randomized control trials showed the image-enhanced endoscopy, such as BLI or LCI, detected more early gastric cancer compared to sole white light endoscopy. So image-enhanced endoscopy is also good for detection of early gastric cancer. So how about characterization? It means a differentiation between neoplasia or non-neoplasia. For squamous cell carcinoma, as I mentioned, multi-center randomized control trial show that the better diagnostic accuracy of NBI compared to white light image. And for gastric cancer as well, with IEE and magnifying endoscopy, according to presence of irregular microvessel pattern and the presence of demarcation line, magnifying NBI significantly improved diagnostic accuracy. And another prospective study also show that they use same diagnostic criteria, but different endoscopy system developed by different manufacturer. So it also shows the better diagnostic accuracy compared to white light image. So image-enhanced endoscopy, especially with magnification, improved characterization of the lesion. So at last, I want to explain about staging. So once we make diagnosis as a neoplasia or early stage cancer, we have to make diagnosis of extent of the tumor and make diagnosis of depth of tumor invasion to decide whether lesion has indication for endoscopy resection or not. So diagnosis of extent of early gastric cancer, so far there is a 4 randomized control trials. So initial 2 single-center randomized control trial proved that the magnifying BI is better than chromoendoscopy. However, recent 2 large-scale multi-center randomized control trial did not show a significant benefit of
नहीं मैं बंद कर दूंगा
magnifying BI.
मैं तो इसको बंद कर दूंगा कुछ बात नहीं
However, it is important to know that this is both magnifying
राजी
NBI, both IEE,
ठीक है
both
बंद कर दो
image-enhanced endoscopy, magnifying NBI and chromoendoscopy, because the chromoendoscopy is already standard method for delineation of the early gastric cancer. So then they compare both image-enhanced endoscopy, different type of image-enhanced endoscopy. Probably both method is much better than white light diagnosis. So probably both method can be used as a standard method for diagnosis of extent of early gastric cancer. So how about depth of tumor invasion? There is no evidence to support usefulness of NBI vessel evaluation for make diagnosis of early gastric, depth of invasion of early gastric cancer. So we usually rely on morphological finding of early gastric of the lesion. So intramucosal lesion, if we inflate much air, it can be stretched because the lesion is still confined to the mucosa. However, the submucosal invasive cancer, if we inflate and stretch the gastric wall, the lesion protruding according to invasive cancerous tissue with lifting surrounding non-cancerous mucosa like this. So chromoendoscopy can facilitate evaluating such kind of morphological characteristic. So this finding shows a very good diagnostic accuracy, but this is retrospective study, so we will validate this method with prospective study. So diagnosis of depth of tumor invasion of squamous cell carcinoma, NBI magnification, vessel appearance is very useful. It shows more than 90% of diagnostic accuracy for diagnosis of depth of tumor invasion of squamous cell carcinoma in the esophagus. And my colleague, Dr. Liu, showed that according to systematic review and meta-analysis, magnifying NBI shows almost a similar diagnostic accuracy to EUS and much better accuracy compared to non-magnifying image-enhanced endoscopy. So at last, I want to show 2 cases of esophagus and gastric cancer. So in white light image, it looks like reddish, irregular mucosa. And in the central part, you can see some nodular change of the mucosa. And with NBI, you can clearly recognize extent of the lesion. And with magnification, you can identify irregular vessel within the clear demarcation line like this. And the periphery, you can see loop-like vessel. However, in the central nodular part, you can see non-loop vessel like this. So we can suspect this can be invade some muscularis mucosae or shallow submucosa like this. And of course, iodine chromoendoscopy clearly show extent of the tumor as an unstained area. And EUS show the lesion still preserve some mucosal layer beneath the lesion. So we perform ESD and confirm that the lesion is still confined to the muscularis mucosae. And I would like to introduce the latest video endoscopy system. So this is maybe very good for you outside Japan. This system is compatible with both 100 and 200 series. So you can use 190 scope, and also you can use 200 optical zoom scope in this system. And recently it equipped texture and color enhancement mode, and maybe, as you know, magnifying image, depth of field, depth of focus become very narrow. However, this system equipped expanded depth of focus. So I want to show some image. So this is a patient with atrophic gastritis and intestinal metaplasia. So color texture enhancement enhance the unevenness of the mucosa and the irregular color. And with NBI and somewhat similar to near focus mode, we can observe detailed microvasculature and the mucosal structure like this. And usually magnifying zoom endoscopy, we can see only very narrow area, but because of very expanded depth of focus, we can see clear image of microstructure and the microvasculature in this type of panoramic view. So this is my summary. In many aspects, such as risk classification, detection, differentiation, and staging of early-stage upper GI cancer, recent evidences support usefulness of image-enhanced endoscopy to improve diagnostic yield of endoscopy and to benefit clinical practice. So my last slide, but it is important to understand that sometimes people misunderstand that such kind of technology solve all problem, but it is not true. So technology does not totally take over human insights or technique. So this is also recent meta-analysis paper, and they show that the use of NBI improve detection of colorectal polyp, but with adequate or proper preparation, significance or usefulness is maximized. So such kind of basic preparation or basic knowledge or basic skill is still very important. And on top of that, if you use advanced technology, you can improve your clinical practice outcome efficiently. Thank you very much for kind attention.
Yeah, thank you, Professor Uedo. You've convinced us about the usefulness of advanced endoscopic imaging.
Yes.
I think I'll ask the panel first, is that in India, do we really have cancer esophagus or cancer stomach as important problems that we can pick up early lesions? Dr. Mohan Prasad?
Yeah, thanks, Naresh. That was a wonderful demonstration. I think we in India, we are very fast in our endoscopy. I think all the high-risk patients should be, probably posted on separate days. They should be sedated, properly prepared. And then if we start looking for, I'm sure we may be able to spot more cases. In our routine endoscopy workload, we may miss some of them, but nevertheless, we don't have that sort of early gastric cancer or early esophageal cancer as the Japanese see. We are just seeing them in the late stages. They don't come to us probably. That's why we just miss them out.
Saurabh, you are trained in the US. Your endoscopy training has been in the US, and now you're back in India.
Yes.
Do you hold the same sort of thing, idea that what Mohan Prasad has said, that perhaps we don't see them in the early stage. Why is that? Everything that is to be early will becomes late. I'm sure that's simple logic. So why do you think we're not picking them up, and what happens in the West?
Yeah, so I think in the West, I just have a corollary to colon cancer. And if you see, over time, we have detected polyps early. We have early colon cancer detection, and we know with screening colonoscopies, we've reduced the incidence of cancer. Historically, right-sided flat polyps were not considered polyps to begin with back in 20 years ago, but now we have soon over time realized that there are sessile serrated polyps and that they are precancerous. And then over time, as gastroenterologists started recognizing it and removing those polyps, the incidence of colon cancer right-sided has gone down. So I think it's something similar to gastric cancer. It's the infrastructure that we have, the sedation, the amount of time that we can spend. I'm quite sure that we should be able to detect early cancers in India if we certainly follow protocols and screen the high-risk patients appropriately.
And we know that early gastric cancer precedes advanced cancer by at least 3 years. So we can gain 3 years by better imaging techniques at endoscopy.
Exactly.
I would also agree
Yes.
with Dr. Mohan Prasad that here we spend less time in the upper GI procedures, and probably we need to spend more time. And also, if we do the procedure under sedation, early suspicious cases, I think we should be able to pick up early cancers.
Dr. Paliswamy, in your unit,
Yes.
what is the present norm as far as magnification NBI? I'm using NBI as a kind of a generic term for any advanced endoscopic modality. What is your protocol? Do you use it routinely? Do you use it sort of selectively? How does it go?
We don't use it routinely, the narration. We use it only selectively. When we see a lesion suspicious for malignancy, then at that stage, probably we use it. There's no protocol. Of course, there's some sort of research guide for the fellow in a DNB candidate. We do a research project on this imaging technology. Those cases, of course, we do regularly.
Mohan Prasad, what's your thing? Do you have, again, a screening thing? What is your screening protocol? You said high risk. So what, in your opinion, is high risk for upper GI cancers? We'll stick to upper GI because someone is talking on colon subsequently.
Yeah, actually, we find that squamous cell carcinoma is higher in all these smokers, and also, like Barrett's and going into adenocarcinoma. Those are cases, all those cases we just look with the NBI, but we have the 190 series, the Hexera 3 system. So we just spend time to look at all those. And again, the OG junction, we just focus. We just look at those, magnify and do targeted biopsies, all those we do. Of course, in the stomach, we really search for early gastric cancer in all the patients. And if there is even the smallest suspicion of a small lesion, flat lesion or a protuberant lesion, we always do a magnification and then do biopsy. But, the high risk patients, especially in smokers, and also family history of esophageal carcinoma, people with gastric cancer family history, atrophic gastritis, and all those patients where also we see intestinal metaplasia in the antrum. Those are cases where we concentrate more. We can just give right now, it's also always helpful because under corona situation, we do the endoscopy, all the endoscopies under sedation. So we can take more time. We can even put on the cap and go and inspect. But this doesn't happen in a routine situation. We might miss out. So I think what the message that has to go to all the youngsters is, whenever you stratify clinically that this patient is a high risk patient, he should be allotted probably 30-minute slot and then should be sedated, properly prepped properly without mucus and all that, because I myself missed a obscure GI bleed case. I did an endoscopy and I missed a gastric ulcer myself, and I spotted it myself on capsule. We went back and saw there was mucus in that area. The preparation was not good, so we missed out the gastric ulcer on an endoscopy, picked up on capsule, again went back with the endoscope. So I think prepping the patient is very important and doing it under sedation. I think these patients should be stratified and separately posted, just like you post for therapeutic cases.
Okay, thank you, Mohan. Let me ask Professor Uedo, really, now Mohan Prasad said you need to allot a lot of time. What is the recommended time for an upper GI screening endoscopy that is really needed?
So it's a bit difficult question. It really depends on the skill and the experience on, and also situation, like case volume.
How long do you take? How long do you take?
Usually one slot is 20 minutes, 15 to 20 minutes. And the actual procedure, we usually spend maybe 7 to 10 minutes. If we found some suspicious lesion, extra time, extra 2 or 3 minutes, but usually 7 or something. And
so it does not take a whole lot of time that people think that you'll be wasting time. It's actually not. Once you're trained, it's 7 to 10 minutes for a good examination.
I think so. Yeah.
Let me also ask you a provocative. Let me ask you a provocative question. All over the world, they talk about Japanese endoscopists, Western endoscopists, or non-Japanese endoscopists. What makes the Japanese endoscopist so committed and so much of a thing to be so perfect? Why is this attitude so different? Do we need to learn something from the Japanese endoscopists? Is it just patience, or is it the training, or all Japanese endoscopists like that, or are there people who take shortcuts in Japan as well?
Maybe you meet some very selected patient, selection bias. You meet doctor attending a workshop or a congress, so maybe selection. I know not all, but.
So in your training, even when they start off without advanced imaging, without NBI and basic white light endoscopy, do you also sort of train them to take a lot of time and spend time and do?
But I think it's like if you do perform something routinely, you learn spontaneously. So basically, we use ImageEnhanced NBI or something every time or every procedure, and we usually pick up some interesting case. So in a conference, we usually discuss and share the endoscopy image or something. So maybe routine practice so that the young doctor can learn spontaneously. So do it routinely is very important.
Saurabh, a last comment from you is how would you train your resident now in India to do endoscopy now that you've seen the best of the West, you've been exposed to the best of Japanese endoscopy, and you're now practicing in India? Saurabh? Saurabh, are you there? No. Dr. Pandeswamy, would you like to take that?
Can this advanced imaging technology replace histopathology? That's the question to Udo. Can this advanced technology, imaging technology, replace the histopathologist, biopsy?
Dr. Uedo?
Yes.
Has advanced imaging replaced histopathology?
I think not totally, but in some part, we can say it looks really confident if it's non-neoplastic or neoplastic. Compared to source white light image, we can predict histological finding more accurately. So I think in some part, we take place histological finding, like biopsy. Not 100%.
Do we have Dr. Suraj? Dr. Suraj or Dr. Gulshan on the screen? Suraj, any comments that you'd like to make? What are your challenges in advanced imaging in Imphal?
So this northeastern part of India is quite different from the rest of India. So unlike the rest, we have a lot of GI cancers, and definitely we have a lot of esophageal as well as stomach cancer. So we have started screening these high-risk candidates, like persons who have a chronic history of alcoholism.
Yeah, Mohan Prasad alluded to that. So
yeah, and then like we are starting to pick up patients with early gastric cancer, and we do ESD. One of the challenges, our hands are, as already being detailed, our hands are all full. Like we are doing a lot of procedures like US ERCP. So we need more time to dedicate for image-enhanced endoscopy. And one more thing is like the issue with this scopes and instruments, they are a bit costly. So this is not only for me, but for entire India, where these Zoom scopes are like, they're specialized and they're very costly, and there are cost issues with this. And then we need a lot of time for these patients so that we can pick up early like GI cancers.
Dr. Gulzan from Kazakhstan, are you there?
Yeah, she's not there.
He's not there? Okay, any comment, Mohan Prasad, last comment, and then we wind up?
Yeah, actually, I wanted to answer the question that you were asking. The Japanese, right, for decades have been trained to look for early gastric cancer. Because when I visited Kyoto and Chiba way back 40 years back, I used to see every case they used to spend at least 20 to 30 minutes in normal endoscopy. Everything, I'll ask the professor, what did you see? What is this? Was there something? And he'd say, no, this was normal. Then why did you take 30 minutes? But we very meticulously look for early gastric cancer. I mean, that sort of thing, as you start seeing more and more of early cases, then your eyes can get trained. We, in our own endoscopy institution, we have spotted early squamous cell carcinomas, early gastric cancers. We have done EST, EMR, and removed them. I also had presentation earlier on that. So I think it is possible to train one's eyes to look at those with more care and also with more training.
Thank you. I think we'll end this session. Thank you, Professor Uedo, for being with us on this Sunday evening. And thank you, Dr. Palaniswamy, Mohan Prasad, Suraj, and Saurabh. Thank you, and back to you, Anil.
Thank you, Dr. Naresh. I am extremely thankful to Professor Uedo, Dr. Naresh, and the whole team of expert panel members who are discussing about the recent advances in image-enhanced endoscopy. We may have lost a battle with Japanese in terms of early detection, but we, as Dr. Mohan Prasad said, we are the fast runners in endoscopy. At least we have won some battle in athletics, if not in the endoscopy, without realizing that on long-term basis, we are the losers. So if we take one lesson, I think it is high time we take some good time to screen every patient rather than trying to characterize and categorize the subgroup of the patient, especially with smoking and gutka chewing habit being rampant, at least in north part of India. We, I'm sure, must be missing out large number of cases could be diagnosed early. As Dr. Naresh said, majority of these start with smaller cancer. At some point of time, somebody has to pick up the early cancer. With that, we come to the formal end of the first session.